always have that case or some case in the OPD which simply doesn't respond to us and our treatment, and we start thinking, what am I missing or what am I doing wrong? So this would be a very nice session for us to clarify our doubts. We have multiple case presentations. We have a very expert panel to clarify our doubts and then update ourselves on treating these untypical, atypical infections and certain bugs which we do not understand at the first go. So without taking much time, I'd like to hand over the session to Dr. Paras. Dr. Paras.
Yes, thank you, Dr. Gyan, for this opportunity. Good evening, one and all. Uh, I welcome you all on behalf of Cornea Society of India. We all are faced with clinical situation where sometimes we face a corneal ulcer and we think of usual suspects and you start the management. And at times the condition worsens, or else the clinical presentation is very unusual. You are not very sure what you are dealing with. There would be a diagnostic dilemma. So, and quite often we face these challenges. So, for that, we have this seminar on the subject of unusual microbial keratitis. Without taking much time, I would just like to say that today we have 6 interesting cases shared by various presenters, and we have the experts who is who of cornea, especially the microbial keratitis. And we have Dr. Bhupesh Bagga from LV Prasad Eye Institute. We have Dr. Radhika Natarajan from Shankar Netralaya, Dr. Revati Rajaraman from Arvind Eye Care, Coimbatore, and the rest of the 2 people, eminent microbiologists, Dr. Savitri Sharma ma'am and Dr. Joita Joseph from LVPI. None of them need any further introduction. So without delaying further, I would like to suggest that brace yourself to go through interesting cases and throw your questions into the chat box. Alongside with me, I have Dr. Purvasha Narang helping me out for moderating this session. So over to you, Dr. Purvasha.
Thank you so much, Paras ma'am, and I welcome on behalf of CSI everyone to this Kera Grand Round episode 4, and we will have the first presenter, and that is Dr. Neet Mehta. He is a cornea fellow from LV Prasad Eye Institute, and can we have his video now? Yes, thank you so much.
Hello, I'm Dr. Neet Mehta, and I'll be starting with one of the cases titled Odyssey of Microsporidial Stromal Keratitis. Patient is a 47-year-old male hailing from Maharashtra. He came with a complaint of whitish opacity in the left eye since the past 6 months, associated with progressive diminution in vision. He gives a history of granulomatous anti-eye uveitis in the past and a history of tuberculosis, and he does not give any history of trauma. On presentation day 1, he had a visual acuity of 20/60 parts in the affected, that is the left eye. There was presence of a whitish, fluffy, cloudy-like stromal infiltrate involving mid-stroma with a size of around 3 into 2.5 millimeters, and there was an absence of an epithelial defect. On careful examination, there were presence of surrounding pigmented keratic precipitates and a central corneal edema. Confocal scans were also done at this visit, and scraping was deferred because there was more of a mid-stromal involvement. So the provisional diagnosis at this point was suspected to be microsporidial stromal keratitis, the differentials being fungal, viral, or any other atypical organism. He was planned for a corneal biopsy, and meanwhile, because of high suspicion, he was started on topical voriconazole 1% eye drops every 2 hourly, along with oral albendazole 400 mg once a day. He underwent a corneal biopsy. He presented 4 weeks later with a visual acuity of 20/60 parts. He was started on topical steroids from elsewhere. At this visit, the biopsy report was suggestive of microsporidial stromal keratitis. The sutures were removed as were taken in the corneal biopsy, and he was advised to stop topical steroids and review back in 2 weeks. 6 weeks later, he presented with a visual acuity of counting fingers close to base. There was worsening of corneal infiltration with 50% stromal thinning and presence of hypopyon. He was rescraped, and microbiology again showed presence of numerous microsporidial spores. At this visit, tissue adhesive and bandage contact lens were placed and started on topical fumagillin 0.07% eye drops 6 times a day, apart from the voriconazole eye drops. Subsequently, there was slow consolidation of the infiltration that was noted. At 6 months visit, there was predominantly inflammatory signs, and hence loteprednol etorbun 8.5% eye drops were added 2 times a day. 8 months visit, the tissue adhesive was removed, underlying which an epithelial defect was noted and which was scraped. The microbiology showed no organism. Topical fumagillin and voriconazole 4 times a day were continued along with lotepred eye drops 2 times a day. 9 months visit showed predominant scarring. His visual acuity had improved to 2160 on pinhole. The OCT also corroborated with the scarring that was noted, and confocal scans were repeated to check for any presence of spores, which were not seen. The same medications were continued at this visit, and subsequently the lesion had scarred. This is a year later image. He started to develop predominantly vascularization later on, and hence was planned for a penetrating keratoplasty. Post PK on day 1, voriconazole eye drops were continued for almost a month at 4 times a day. Steroids were started along with antibiotics and cycloplegics. Post PK, he underwent selective suture removal, and then with a healthy endothelial count, he was planned for a cataract surgery. This is his recent follow-up of 3 years with a visual acuity of 20/30 with minus 2.5 diopter cylinder at 100 degrees. Some of the important learning points include prolonged medical therapy has the potential to eradicate microsporidial stromal keratitis. Confocal scans can be used to assess resolution of infection, and delayed keratoplasty after complete microbiological cure can achieve good outcomes. Thank you.
That was a wonderful case uh, by Dr. Neet, and we would like to have comments from Dr. Bhupesh, like how many cases of microsporidial stromal keratitis do respond to only medical management, like what percentage? And if we do not have an access to fumagillin, would it be all right to initiate the management only on voriconazole and the other supportive management?
Hi, Dr. Paris, and thank you for the question. Am I audible?
Yes.
Yes.
So we have treated from past 2020, means around 6 years now, around 20 patients. And out of these 20 patients, 2 were having non-clinical response and they needed therapeutic keratoplasty. But rest all responded, and 2 of them needed optical keratoplasty as well for visual acuity improvement. Many of them actually responded well with the decent visual acuity. So it suggests that with the combination therapy which we are giving to these patients, fumagillin along with voriconazole, with a prolonged treatment of nearly 6 to 8 months average time, the resolution is happening.
So what is your standard protocol, Dr. Bhupesh? Like,
If I get confirmed microsporidia on smears, then I start 0.007 fumagillin eye drop for at least 2 hourly to 3 hourly for at least 2 weeks, and then continue the patient on albendazole 400 milligram twice a day for 1 month, along with the consultation of physician, and voriconazole topical eye drop also 2 hourly. But many of these patients we have seen that they are on steroids when they present. So the moment you initially, when you used to stop steroid, they used to come with worsening, sudden worsening, or sometimes they come with the thinning or hypopyon, or sometimes severe pain. So what I started doing from past few years, that I used taper steroids, slow tapering of steroids, and keep them for at least 1.5 months or 2 months on some low grade steroids once or twice a day. And then off and on, sometimes they need steroids, but most commonly after 1.5 months, they don't need any treatment except this combination of fumagillin and voriconazole. So after 1 month regime, only topical medication with stopping of oral albendazole. So this is how this the cases are there. And the question that if you don't have Fimagillin, only voriconazole, we have a few patients where the voriconazole was given because of unavailability of Fimagillin due to sometime because of COVID or some other reasons at that time, but the response was not there. So I realized that this regime is working well in a combination therapy.
Dr.
Dr.
Revati,
Baga, where do you get that Fimagillin?
So
Because we tried, yeah.
so we are getting now from Sigma, and we are getting previously we have tried actually 3 sources, but now this is past 2 years we are getting from Sigma, and we are getting in powder form, and we're preparing in our pharmacy. Initially, Dr. Savitri was there when she used to prepare in microbiology, but now we have dedicated pharmacology services where Dr. Gautam is there. He is preparing 0.007%. And we are giving to the patient 3 bottles because 1 milligram prepare 3 bottles, and we have to keep these bottles under refrigerator. So 2 bottles should be kept in -20, means where the ice box are there, and 1 bottle we keep in the door so that whichever patient is using that need to be there, and that is very crucial, the cold chain maintenance. Otherwise, this drug is not working.
So
And the cost?
getting this drug from LVPI pharmacy would be difficult in the sense maintaining the cold chain for the patient as well, isn't it?
We have tried once, only one experience that I sent to Bombay with the tissues, when they're sending the eye bank, they got it from there because the patient was not able to come. But overall, patients are usually we see every month these patients, or 1.5 months, sometimes 6 weeks. So they are coming. So we initially we call them every 3 weeks, then after every 6 weeks. So then they're coming after 6 weeks, we give them drops. So that's how the things are moving till now. The cost is now reduced. Initially, it was 6,000 rupees per 18,000 rupees per milligram. So 6,000 rupees per bottle. Now it is 2,000 rupees per bottle. So this is around 6,000 to 7,000 for 6 weeks treatment. That's what is patient has to pay. And being at LVPI, if not able to afford, we are giving uh, half or free or whatever the patient can afford.
Dr. Revati ma'am, how do you manage such cases of stromal microsporidiosis?
Because same thing. I tried also. I contacted Dr. Baga for Fimagillin. Same thing. Because of the cost restraint and other things, I couldn't start. So I use same oriconazole, and sometimes we use either PHMB or one of that biguanides, and I'm using oral albendazole for a longer time. And many of the patients, they tolerate well, including a patient who is having chronic immune nephritis. So she has to be on immunosuppressives. They couldn't reduce it. But with their permission, I'm using albendazole. I used it almost for 6 months, albendazole. But she could tolerate, and maybe another one more patient also like that, and around 6 months. A slow scarring I could see. But what I notice, as Bhaga said, sudden deterioration can come. And I feel because lack of Fimagillin, sometimes I go for keratoplasty only. If at all we are doing a therapeutic, better to go for a penetrating rather than lamella. It looks like as though it's in the mid-stroma or stroma, but you do ASOCT, you can see the deeper KPs and all. And for this immunosuppressive lady, because it went up to the limbus in one eye, I did a large DALK, T-DALK. Initially, she was doing very well, but then gradually again it started coming back. But the other eye, she had bilateral. The other eye also central lesion, so somehow with great difficulty convinced her to better to go for a penetrating therapeutic rather than waiting for it again because I couldn't control it that much. So penetrating with a very good optical quality graft, still it survives, and because she is on immunosuppressive also, and I'm continuing the same topical medication. But looking at Baga's experience, Fimaglin, if it is easily, I mean, at least like biguanides, if it is available for everybody, it will be really helpful for the patients.
Thank you, ma'am. Radhika ma'am, your technique of the corneal biopsy is pretty famous, ma'am. If you could share it again with us in those cases where the initial scraping is negative.
Yeah, sure, Purvasha. Even before that, I think there are a lot of learning points in Dr. Neith's case. So basically, the fluff of opacity, which is whitish in color, not yellowish, the fluffy appearance, the midstromal location, the lack of the epithelial defect, small KPs around it, these are all, it's like the microsporidia read the textbook and came. So, for the audience who's not familiar with these cases, I think it's a very good case to learn from. And he has rightly employed the technique of the trapdoor biopsy, which I favor a lot in these cases. Here again, when you don't have an epithelial defect and the disease is, the infection is deep down in the stroma, the biopsy helps a lot. The way I do it is create a triangular flap of the cornea very similar to a trabeculectomy flap. In the normal cornea adjacent to the infiltrate, you should not violate the infiltrate itself because that area will be not very healthy cornea. So to put the flap back is going to be difficult. So once you raise the flap, then the infiltrate will immediately become visible. Then you take scraps of it like you would do a corneal scraping. And you need to break it up into small parts because if you give bulk of tissue, Savitri ma'am will agree with me that the cellular debris and everything will mask the tiny organisms. So you have to actually tease out the small bits that you give into thinner portions before you hand it over to microbiology. The good thing about this flap is that if there is any area of thinning or even if you have a perforation at hand, all you have to do is to put the flap back with either glue or suture. So the trapdoor biopsy is probably very much indicated in a case like this. Couple of points about the management is voriconazole and oral albendazole alone, the results are not all that great. Once in a while, anecdotal case may benefit, but without fumagillin in the picture, which I have not tried out yet, the results are not great. And if we do a therapeutic PK, like Revati ma'am mentioned, we can immediately put these patients on topical steroids as opposed to pythium keratitis or fungal keratitis. We can give the graft a survival for optical purpose by putting steroids immediately. And last but not the least, it's very important to caution these patients not to expose themselves to the same water source where they got the infection from. Quite often, the recurrence happens not immediately, but years later. And I suspect it's not the organism that is harboring there like acanthamoeba, but probably the exposure to the same source that is happening again and again. So these are some pointers that I follow in the management of these cases.
Right. So there's a question.
Savitri ma'am, I have one question. When I attended one AIMS meeting, the same microsporidia I presented, then when I mentioned that it's a deep lesion, so we went for biopsy. Another microbiologist came from, I think, Madhya Pradesh or something. She said even then you can try a conjunctival scraping. Still you can see microsporidia in these cases. I'm not sure. Is it true?
No, we have not been able to see that. And about albendazole, I thought I'll add something. The evidence is not really good about using albendazole for a long time. And logically also, the organism has nothing to do with the intestine. When it is in the eye, it is actually coming from outside and not from the intestine of the patient. So it really controversial whether we should give albendazole for a long time. The evidence in the literature is not very strong about it.
One point I would like to make is that, I mean, it's very easy for the general microbiologist to pick up microsporidia, which I was quite amazed to observe with our own microbiologists that, so that in case you are thinking that, your microbiologist may not be able to pick it up, they have, already an access to many other, lesions. So Our microbiologist picks it up very, very fast. So it's easy to diagnose, right, ma'am? Like comparatively. Only thing is we have to look for it in the, yes.
In
Yeah.
fact, they like it from the eye sample because when they see from stool sample, they have a lot of garbage around it and it looks a lot of artifacts. So they're very happy to see the eye sample which doesn't have any artifacts except for epithelial cells. Neat, you can see the number of these spores. I wanted to ask, how come we don't have pictures of these when the presentation was made? Neat? How come we don't have pictures? People
I
should benefit from
yeah,
that, isn't it?
I'm sorry about that.
Biopsy as well as microbiology, no pictures.
Yes, maybe we could have in some other time.
The microbiologist is indeed disappointed. I can understand that. Right. So, ma'am, probably next time we'll put it up. So there's
Shall
a
we?
sequel for this.
Yeah, there was one question that should we intervene? Those people who do not have an access to fumagillin, should we intervene early for therapeutic keratoplasty so that it can behave as, maybe probably an optical graft, Dr. Bhupesh or Dr. Revati ma'am? You would like to comment on this?
Yes, my approach is like that only. Very rarely I have seen patients healing. So I prefer if it is a significant size and if I see a lot of KPs in the posterior, I mean in ASOCT, sometimes I can see even anterior chamber cells in the ASOCT, then in that stage I would like to intervene surgically and I would like to go for a good optical grade graft. As Radhika said, we can start steroid immediately in these cases. And when we
Yes.
can get a very good clear margin all around, that is the time we have to intervene. And you give good steroid, we can start, and sometimes it can survive even your therapeutic graft. Ma'am, Savitri ma'am, one more doubt I have. I had another patient bilateral, uncontrolled diabetic patient, and she had in both eyes, both microsporidia, that is by biopsy, and when the scraping revealed bipolaris, but in
Fungus.
the fungus bipolaris in
Clinically,
both
clinically,
eyes.
was there a sign that both can be there?
No, one eye when she came, it was a total necrotic cornea. So straight away we went in for therapeutic graft. That necrosis before going, when I scraped bipolaris grew. But the initial picture, the referring doctor clearly mentioned that it looked like only microsporidia. So anyway, we went ahead and did the therapeutic, and the biopsy revealed only microsporidia. Maybe they didn't, I didn't ask them to look for fungus in the specimen. The other eye also again smoldering lesion like this. It went for grafting again. In that also, that eye also bipolar is. So I
So
wondered,
I think and you are saying it's a long-standing case and necrosis has set in.
long standing.
So all that white, so it can invite secondary infection
Okay.
for such a patient with a long-standing the ulcer, and that too
Okay.
when it is necrosed, and you are probably treating only for microsporidia, secondary infection can come in. Both can be present.
But voriconazole anyway we are using, but still she had that. I don't know.
Thank you so much for the lovely insights, Savitri ma'am and Revati ma'am. We would like to now move on to the next cases. So the next up is Dr. Sai Lahari's case. She is a cornea and anterior segment fellow at LV Prasad Institute, Hyderabad.
Welcome everyone for the Kera Grand Round Season 4. I am Sai Lahari. I will be presenting a case on atypical mycobacterial keratitis. A 27-year-old male presented to the OPD with complaint of pain, redness and watering in the left eye since 3 months. The chief complaints had delayed onset, gradually progressing with waxing and waning course. History of injury in the left eye with some foreign body 3 months back, and the patient had been using steroids along with antibacterial therapy for 3 months. On examination left eye, vision was 20/20 parts. Cornea had small central 2 into 2 mm deep stromal infiltrate. Scraping was negative and the patient was started on empirical treatment. 2 days later, a deeper scraping was taken where smear showed acid-fast positive thin beaded bacilli suggestive of Mycobacterium species. The patient was prescribed amikacin 2.5 eye drops every hourly along with cycloplegics. Later, culture report has come positive for Mycobacterium abscessus, which was susceptible to amikacin. After 6 weeks, the vision was 20/400. There was increased intraocular pressure of 33 mm mercury. Cornea had central 2 into 2.4 mm infiltrate with adjacent corneal thinning of 70%. Endoexudates of 2.5 into 2.5 mm inferiorly and cells. The patient was started both on oral and topical anti-glaucoma medications. Patient was also started on oral clarithromycin 500 mg BD and the patient was planned for photodynamic antimicrobial therapy. 2 weeks after PD80, the best corrected vision improved to 20/160. On examination cornea, TA-BCL was in situ, rose Bengal staining of the TA was present, 3.4 into 3.4 mm deep stromal infiltrate present, AC had trace hypopyon and the same treatment was continued. 1 month after PD80, the TA-BCL was still in situ, rose Bengal staining of the TA was present, deep stromal infiltrate of size 1.5 into 2 mm with KPs was present on the superior edge over the TA. Hence, slow improvement was noted where the inferior edge of the infiltrate is consolidating. The patient was continued with amikacin 2.5% eye drops every 2 hourly along with cycloplegics and topical anti-glaucoma medications. 2 months after PD80, the best corrected vision was 20/100. TA-BCL was lost. The infiltrate healed completely with leukomatous grade scarring with dense, deep and superficial vascularization. Hence, the learning points, the key features of atypical mycobacterium include delayed onset, weeks to months, indolent course, non-responding to standard antibiotics, cracked windshield or branching appearances, and strong link to LASIK, trauma, or contact lenses. The duration of presentation, clinical presentation, special microbiological stains, targeted therapy, antibiotic susceptibility patterns are the key to successfully manage these cases. Thank you.
Thank you so much, Dr. Sai, for sharing this interesting case with us. Next up, we are also very fortunate to have a case contributed by Dr. Uma Sridhar ma'am. She's the senior consultant in cornea, cataract, and anterior segment services at Eye Care Hospital, Noida. And she's also the author of the comprehensive and the much discussed Cornea Atlas. So, welcome, Uma ma'am, and over to your case.
Good evening. Today I will present a patient, 34-year-old male patient who presented with blurring of vision in the right eye after an insect fell into the right eye 1.5 months ago. He had treatment at various places and his latest treatment was with natamycin, moxifloxacin and prednisolone. His best corrected vision was with pinhole was 6.9. There were multiple pinhead-shaped infiltrates with keratic precipitates. Here you can see under the green filter, the multiple infiltrates and the keratic precipitates. The differential in his pressure was slightly high. The differential diagnosis was infection with Microbial or atypical microorganisms, mycobacteria. Scraping was done. Natamate was continued. Fortified amikacin was added hourly. Prednisolone was stopped. IOP was raised. Hence, mesopt eye drops were added. After 3 days, he presented after natamate was continued and fortified amica was started. He presented with a slightly coalesced infiltrate. The scraping report now came in and acid-fast bacilli with 20% acid-fast was positive. And there was growth on blood agar and chocolate agar. The sensitivity report showed he was sensitive to tobramycin and not to amikacin and also to linezolid and clarithromycin. So the amica was changed to 45 tobra and linezolid was added and oral clarithromycin was also added. You can see the progress of the infiltrate. It started healing very well. A small hypopion appeared on October 25th, and it actually coalesced into this form on 31st. On topical clarithromycin was added after 4 days since the patient was not able to take oral clarithromycin. So here you can see the progress of the infiltrate. Here on 6th, on 15th, 20th, 25th, 29th, 31st. So it was kind of a waxing and waning. It started improving on November 12th and November 17th. When he was using oral clarithromycin, actually it improved. And when he stopped, and we also started topical clarithromycin, when he was not able to use it, the infiltrate actually increased. Later, it started scarring with vascularization. So he was actually on off and on clarithromycin and on oral clarithromycin and topical clarithromycin off and on. His final best corrected visual acuity was 6/9. Thank you.
Thank you so much. Savitri ma'am, you were saying something?
I wanted to show something in the gram stain that she had projected. Can we go back to that? Or is it
It's a
difficult?
pre-recorded video, ma'am.
Yeah, okay. All right. So in that gram stain, what was told in the earlier presentation without showing pictures was unstained bacilli. They were seen very beautifully in Uma's slides. You in gram stain, because not everybody will do the acid fast stain initially. And you would only see they do gram stain and KOH. If you have calcofluoride, you do that. So in gram stain itself, you can suspect mycobacteria by looking at those unstained bacilli. They were very clear in her smear.
Ma'am, I do remember this from my fellowship days that you had taught us that if you see unstained bacilli, it is quite likely that you are dealing with ATM.
Yeah, and use the same slide. Take a picture of that unstained. Use the same slide. Don't have to go to patient again and stain it with the acid fast stain. It will become very clearly. You will see much more of those mycobacteria or red colors than you would see the unstained ones.
Both the cases were fantastic cases. I would like to open this up for the panelists. Dr. Radhika, would you like to have some comments on both the cases?
Yes, this is a very rare infection. In fact, we had also submitted quite a similar case with the same Mycobacterium abscesses as the causative organism. It's very difficult to diagnose upfront because nobody thinks of atypical mycobacteria as the first organism when you deal with a corneal ulcer. But if you see cases, a pattern may appear. These also quite often have history of injury with vegetable matter. Quite often they look like a small gram positive infection, like the gram positive bacteria when they staph or strep2 they cause an infection. So a localized stromal thick infiltrate is how they present. But then how they differ in my small experience of cases is they start developing an endoexudate, which usually the streptococcal or the staphylococcal infection will not develop. So the endoexudate quite often seems to be disproportionate to the size of the infiltrate, and it starts extending, into the anterior chamber. So that is a red flag. The second red flag that I have noticed is that if we keep looking for the cracked windshield appearance, it never presents with that. It somehow seems to come in the middle of the treatment. I think the explanation for that is when the organism starts migrating along the path of resistance to in the cornea. So that kind of appearance comes later. The biggest red flag is steroid is a strict no. If there is one infection in which you don't want to start topical steroids unless and until you want to give the case to your inimical opponent for treatment, is that is atypical mycobacterial infection, because steroids not only cause flare up of the infection, it causes a lot of waxing and waning later. Oral clarithromycin, I think both the presenters emphasized. I think that's because of the anterior chamber involvement and the endoexudate. Oral clarithromycin has got a huge role in the treatment. Normally in corneal ulcers, we don't employ systemic antibiotics that much. And last but not the least, we are still ophthalmologists. We are not internists in that sense. So better to take a physician opinion. I found out when I was treating a patient that oral clarithromycin can cause electrolyte imbalances in prone individuals. So it is better to take their opinion. So the presence of the history of injury with organic matter, the small ulcer but an endoexudate, the later presentation of a cracked windshield, the importance of topical clarithromycin and taking internist opinion are my small takeaways in treating this particular infection.
What would you prefer between linezolid and topical clarithromycin? Topical linezolid and topical
I
clarithromycin.
have till now treated with amikacin and oral clarithromycin, Savitri ma'am, for the reason that I told you that in my opinion, when there is an endoexudate, there is a chance of systemic medication working because the blood aqueous barrier is broken, and whatever you give orally through the bloodstream, it gets into the aqueous and is able to reach the infection, which is not the case in most corneal ulcers. So rather than adding topical clarithromycin as the second drug, I would give oral clarithromycin if there is a deeper involvement, which I have seen in most NTM cases.
May I say something? In our patient, topical amikacin was resistant, so we gave topical tobramycin, and topical linezolid was also sensitive, so we gave that. Oral clarithromycin, as you said, Dr. Radhika, I was not very this one about giving it for a long period of time, so we gave it for a week. Then the patient himself stopped it. Then we said, let us start a topical clarithromycin, but he was not very comfortable with that 1%. In fact, we gave him a little stronger also, and he was not comfortable with it. So, and he was a man of his own mind. So he would by himself stop and start and stop and start and tell me that this works for me and this doesn't work for me. And so he was taking a lot of interest in his own treatment. So it was half him and half us.
This
Can
is
I
one
ask a question? I
Uma
actually
pointed out takes a very long time to resolve. I think patience is very important and follow-ups are very important. It may take even 4 to 6 months to resolve completely.
Thank you, Dr. Radhika. There's a question for Savitri ma'am and Dr. Jovita both. Like how difficult or easy it is to get the culture sensitivity report done, because we have to send our culture sensitivity to Hinduja Hospital. So is it possible to get it done in LVPI or the big institutes?
So at this point, we are doing it the same way as we do for any other bacteria, which is the disk diffusion method. And only thing is, instead of the routine 24 hours, sometimes it takes about 48 hours to get for the organism takes longer to grow. So the results takes about 48 hours to get adequate growth and for the results to be interpreted properly, adequately, correctly. So in continuation with that, in fact, that was one of the questions which I wanted to ask Radhika, but Uma ma'am also did answer that she saw a strain of amikacin resistance. When I reviewed the results in our data, we did not find a single strain that was amikacin resistance. So I wanted to ask, in fact, how common is amikacin resistance for you all?
The numbers, I don't know if you are asking me, the number of infections that we see of this particular organism are not that many to, give an emphatic answer. But I would agree with you that amikacin resistance was not seen in our cases also. So in that event, like Dr. Uma said, topical linezolid is an option. Again, a word of caution about systemic linezolid. So, as an extension, if we can use systemic antibiotic, why not systemic linezolid? Causes a lot of immunosuppression. It is on par with antimetabolite agents. So if at all there was a resistance to topical amikacin, then topical linezolid, which has shot to fame thanks to all of your people headed by Bhupesh for treatment of pythium keratitis, is a handy tool to have over here. But amikacin has worked so far in our cases with systemic clarithromycin.
Savitri ma'am, would you like to comment upon this picture?
I agree that we have not seen amikacin resistance in vitro. And if it is reported by the microbiologist, probably we should look clinically whether it is responding to amikacin. And if it is still responding, probably we can wait for a while rather than thinking of changing the medication.
Ma'am, Dr. Uma's slide is put back.
I would
Would you
like
like
to
to comment
acknowledge
on that?
Sapra's lab, ma'am. Dr. Neelam Sapra, who was your student,
Yeah.
Dr. Savitri, ma'am.
Yeah.
That's her lab.
Yeah. So was it clinically not responding to amikacin?
When it started, when we started with amikacin, I showed you, it coalesced into one thing, 3 to 4 millimeters. It actually consolidated. It was not really responding. So that's why we shifted it.
Okay. I
That's
think
it.
we have to look at that. Here in the gram stain, you can see the picture on the right. In the clear area, you can see bacilli. A bunch of those. Because you are seeing in acid fast stain also a group of those acid fast. So here also you have group of unstained bacilli. So that's very clear. That's the one which gives you the clue.
Okay, thank you so much.
Yeah, it's nice.
Also, I have a quick question for Dr. Uma. Of course, there is only so much we could observe from the video. Would you consider a coalition or a consolidation of multiple lesions as a worsening? Because many times, even in a fungal infection, we find that what looks actually worse is because the intensity is increased because they're all kind of grouping together and then the scarring happens. So unless and until there is a thinning or something, would you consider that as a worsening? Mycobacterium abscessus gets its name from that. It forms abscess in the cornea. So, would you still wait it out a little bit or escalate your treatment, Dr. Uma?
Well, when this, Dr. Radhika, when it became denser, rather than you found in the first stage, there were individual infiltrates with keratic precipitates. And then when it kind of joined up and became a little denser, and the sensitivity patterns also showed that probably Tobra would be better. So we shifted to Tobra instead of waiting it out and this one, continuing with Amica.
Right. Dr. Bhupesh, would you like to also comment upon the PD-80 or the photodynamic antimicrobial therapy that was utilized for this case?
Yeah, hi. Yeah, for this case, we have utilized because we have seen that in vitro susceptibility data, which was showing that PD80 was working for these organisms, as well as some cases published by Bascom Palmer group. So we tried for this case because it was not responding as per our initial experience for this patient. So this case showed response, but actually I do not know whether we can claim it that whether this is really had made any change. But yes, for cases which are very poorly responding, particularly to amikacin or having toxicity to amikacin, these can be used because of in vitro evidence.
And how long before we start seeing the actual effect or the resolution of the ulcer?
So usually if you start the therapy, then next day definitely there's usually we find increase of inflammation or haze. So I call usually patient after 3 days, and but response actually of any of this type of therapy takes around 10 days to 14 days.
So what is the depth to which it works, Dr. Bhupesh? Does it, really work for this kind of a deep infection?
Yeah, as per literature and animal trial, it reaches till 220 to 270 microns. So
The
whatever,
usual depth to which any of these procedures reach.
yes. So if you are already thinning and you are debriding the epithelium, surrounding epithelium, then and this is inflamed the cornea. So we do not know that how much rose Bengal is reaching. If at all is reaching till mid stroma to more than that, because this patient was also having thinning. So probably that it has reached till their organism.
So does the procedure also cause as much keratocyte loss as our riboflavin cross-linking? And if so, I know in infectious keratitis, the first goal is the eradication of the infection. But if there's a lot of keratocyte loss, will it also add to the melting or retardation of the reepithelialization?
No, I have not seen any case melting out of so many cases which I have done for.
Right, right. Okay.
Right.
Thank you, Dr. Bhupesh. And I have one question for Dr. Jovita. Do we have any role of newer, diagnostic techniques like PCR or uh, multitoph or gene sequencing for such cases?
I mean, we are at least excited now because we have Maldi and now we are quickly identifying the species. And we have found that majority of them are the Mycobacterium abscessus complex, but we are getting some other species also. But whether they differ in their treatment, I don't know, because again, all of them are amikacin sensitive. We'll see. We are definitely studying them, and probably we'll know soon whether the outcome is different or not among the species, because until now we were not really studying among the species whether they really differed the outcome, but probably soon we'll know that.
That's
We
interesting,
we
Dr.
look forward to those, results eventually. And before we move on to the next cases, for Russia, Dr. Jayesh wanted to ask some
Yes, Dr. Jayesh had raised
question
it.
for the previous case which was discussed. Do we have Dr. Jayesh Wazirani on the board? Dr. Jayesh, please. Either your comments or Dr. Jayesh.
Okay. Meanwhile, Dr. Jovita, as we know, these organisms can be either slow growing or the fast growers. What do you recommend? What do we tell our microbiologists to keep this culture for at least how many weeks so that we can actually, with certainty, say that this is not growing anymore?
No, these are fast growers. I mean, when you consider a non-tuberculous mycobacteria, it is because they are fast growing. So they will grow within 7 days. Within 3 to 7 days, they will definitely grow. Most of them that grow in our lab will grow on the routine blood agar and chocolate agar, and they grow within 48 hours to 5 days. So there is no need to keep it beyond 7 days. So 7 days is what the protocol we follow, and that should be adequate if you're suspecting NTM. It is only for tuberculosis that we keep it for 2 months.
Thank you so
And
much.
are we seeing, more of like Mycobacterium abscessus as compared to Shiloni and the other one
So
which we used to see
fortitum.
earlier?
So Kiloni and
Fortutum,
fortitum are
yes.
now both in the abscessus complex.
Okay.
So right now we are all getting, everything is coming in the abscessus complex only. But apart
Oh,
from that, there are other species that are coming which are rare, but most of them are belonging to the abscessus complex only now. We are not really differentiating in them as Kiloni and fortitum now anymore.
okay.
Yeah, before the days
Thank
of Molditov, what was available to me was only biochemical reactions. And so based on that, I would get fortuitum or kiloni as per the books we would identify. But now, and no, now people are learning about the DNA and the protein. So DNA sequencing also, when it was done, we found it was called abscesses. And as she's saying now, Molditov also is making it a complex of together as a Mycobacterium abscessus. So terminology keeps changing like that.
Thank you, ma'am.
Coming back to a clinical question, Dr. Bhupesh, how many cases of post-surgical or post-LASIK NTMs do you think are happening? And do you actually need a flap amputation or some other procedure for treating these?
So, how many cases? Definitely, they are not as much as we used to see before. And so now, what we are seeing is uh, post very rarely, like last year only, we could not see much of cases caused by atypical mycobacteria in post LASIK or post surgical. Very few. One case recently we saw post smile. So very less cases are there as compared to before. Regarding flap amputation usually is not needed, but if at all needed, then it doesn't have any uh, problem in the vision, because many of these cases, out of whatever 16 we have published, 9 cases amputated, and visual acuity was same as before. amputation. So it suggests that if you need to sacrifice the flap because of severe necrosis or melting, you can take it out. That can actually help in decreasing the infection. The one point which I can tell in 10 seconds, if you allow, that these both infections, virus, and that mycosporidia as well as atypical mycobacteria, both are difficult to pick up on routine microbiology and often missed as toxic or HSV or something where you give multiple antibacterials and complicate the picture. So once you do not have response, stop everything and think about these two organisms.
Excellent point.
Purvasha, also as an extension to the question that you asked, if at all, 5 seconds, I'll borrow from Bhupesh.
Sure, ma'am.
So if at all somebody sees a postoperative NTM, be it LASIK flap or in a wound, I think the bigger question that begs answering is that where did it come from? So, the referring clinician should also look at water inspection protocols and sterilization protocols to prevent a larger outbreak, because quite often it is representative of something bigger that is happening.
Well taken point, ma'am. Contact lens hygiene, your instrument sterilization, water sources in the OT, LASIK equipment sterilization. I think all these need to be looked into. This is very pertinent. Okay, thank you so much for a great discussion here. We move on to the next case. The next case is by Dr. Yash Patil. He was a cornea and refractive fellow at Dr. Agrawal Eye Institute, the Chennai main branch. Over to you, his case.
Unmasking the unusual bugs. Good morning, everyone. I am Dr. Yash Patil, Cornea Refractive Fellow at Dr. Agrawal Eye Institute, Chennai, main branch. Today, I am reporting a case of Acanthamoeba keratitis. So, a 11-year-old female child came to our OPD with chief complaints of redness in right eye since 1 month, pain in right eye since 1 month, watering in right eye since 1 month, and discharge in right eye since 5 days. She also gave a history of going to the swimming pool 1 month ago. She had visited a branch doctor 1 month ago, and on an examination, there it was noted as circumcorneal congestion and stromal disciform keratitis with pseudodendrites at 9 o'clock position paracentrally with surrounding stromal haze. Her right eye vision noted was 6/24. There, she was started on eye drop Moxie D, eye drop Homide, eye drop Refresh Tear, eye ointment Gancicyclovir, and tablet Acyclovir 400 mg. The ulcer and the condition of the patient was not getting resolved in her next subsequent visits at the branch, after which she was referred to our hospital. When she came in our OPD, on examination, we found that there was lots of congestion and a ring-shaped stromal infiltrated with surrounding edema was noted. Her right eye vision was 1/60 at that time. Corneal scraping was done and the reports came out to be Acanthamoeba cyst on KOH mount. We started on eye drop PHMB 12 times, eye drop chlorhexidine 12 times, eye drop propamabide 12 times, eye drop Vozol 12 times, eye drop Maxim 12 times, eye drop Refresh Tear 12 times, eye drop Homide 3 times, eye ointment Lacrigel 4 times, and on tablet Zerodol SP and Pan 40. These were the subsequent images of the patient on her follow-up visits. There was central 9 mm epithelial defect with central corneal infiltrate, which was seen with 360-degree vascularization. On subsequent visits, the eye drops of the patients were tapered down. ASOCT was also done. The ulcer got healed completely after 2 months. Eye drop Predford was started to reduce the vascularization, and the other medications were also there. B-scan was performed. Then the patient was advised fine needle diathermy with mitomycin intravascular chemoembolization. This was performed to eliminate the abnormal blood vessels and to improve the outcomes of the corneal graft survival. This is the post-op day 1 image post FND with mitomycin intravascular chemoembolization. 1 month post fine needle diathermy with mitomycin chemoembolization. Here we can see leukomatous opacity was present post the corneal ulcer. Then the patient was planned for right eye optical penetrating keratoplasty under all precautionary measures. This is a post-op day 1 image post-OPK. Her vision was 6 by 12 and on 1 month post-op OPK post-op her vision improved to 6 by 9 to 6 by 6. All the necessary post-op medications were started for the patient. Thank you.
Thank you so much, Dr. Yash, for your case. Radhika ma'am, you must have also noticed that a lot of these patients are already on steroids before they present to us. How does that alter our diagnosis or our course of management or the clinical picture, ma'am?
So yeah, I think a situation that all of us are familiar with. While on one hand it reduces both the symptoms and the signs, on the other hand, many of these organisms are not, conducive to being treated with steroids. They flourish under steroids unless and until, in the case of acanthamoeba, you get scleritis, then the immune component is more. So I believe that there's nothing called infectious or immune. Whenever the body is attacked by a bug, it causes direct damage and it also attracts some amount of inflammatory response. And it's a balance that decides whether the steroid will be helping or not. And like I think Dupesh pointed out earlier, these patients are already on steroids and stopping abruptly confuses the clinical picture and makes the patient more uncomfortable. So both ways. So then I adopt what is called as a very slow taper. Instead of making it 4, 3, 2, 1 and stop, then I make it alternate day, twice a week. You kind of trick the eye and the patient into believing that the steroid is still there in little amount. At the same time, salvaging the eye without the organism flourishing also. I have a question for the presenter. What was the role for doing both FND and mice together in this particular case? Why not one alone and not the other?
Ma'am, we were looking for a broader picture. We wanted to do the OPK. So for the outcomes of the corneal graft survival and also for the to eradicate the abnormal blood vessels, we've planned for both the FND and the intravascular chemoembolization.
The reason I ask this question is I should confess that I have not done mice, but I have seen and listened to a lot of people who do the procedure, and I'm sure the outcome was great in your case in terms of the vessel regression, but it requires extremely precise injection of the drug into the vascular channel. And when you have a cornea as opaque as the one that you showed us, then a little bit extravasation into the anterior chamber can also cause profound toxic reaction. Mice is probably more preferred in those corneas where the visibility is little there for the anterior chamber for you to see what is happening rather than FNT will work better in these cases as compared to mice, is my humble opinion.
Okay, ma'am. Okay, ma'am. Thank you, ma'am.
May I say one thing, Radhika? I have tried Razumab when the patient can afford it and Avastin. I don't know, the jury is out on that. But I have a patient who had healed pythium with severe vascularization and 2, 3 injections of Razumab, and he's doing very well. He's 6'9" now after an OPK.
Actually, we
Without any
have one of
vessels.
the very early papers on this, Dr. Uma. We also found some result, but then in my hands, since FNT started giving better results, I kind of switched over. I guess it is not about what we use and it is about the timing. So when you have very early blood vessels, the angiogenesis is just happening, then anti-VEGF works because it targets the newly forming endothelium. On the other hand, completely established vessels, if you want to treat, then a vaso-occlusive treatment like FND is beneficial. In the very early stage where the vessels have not even sprouted, then the anti-inflammatory or the steroid helps. So it's steroid, anti-VEGF, and vaso-occlusive if you go in that order. But definitely there is a scope of overlap like you just mentioned.
I have a question. This florid vascularization we have seen in many acanthamoeba, but can it be also due to the drugs?
Yes, ma'am.
Because we were using for this patient PHMB, then is it really necessary to combine 2 biguanides? Because it's not a derogatory comment or anything. I have known like many people are using, but nowadays with PHMB 0.08%, when you start using, I don't find you need to do use any another biguanide. And of course, we can add maybe antifungal or antibiotic, but that also to the minimum. I don't think all of them hourly And too many medications hourly. Also, drug toxicity is a well-known factor. Even cataract formation is a well-known factor with biguanides when used for a long period. So that also we have to keep it. Maybe like after gradually stopping this medication, if you give time, as Nikhil pointed out, gradually these vessels will regress. And then maybe like, if still not, then you can go for one of these measures. And also I would prefer to wait for a longer time to go for a optical PK in this kind of smoldering infections rather than in a haze.
Thank you, ma'am. Dr. Bhupesh, your experience with topical miltefosine, please, if you can shed some light on it.
Yeah. Yeah, topical miltefosine we have tried in long back, and it doesn't work in our hands. We published this paper also. So based on the hamster trial and then rabbit trial, which is recommended 0.065% topical miltefosine, and they have showed their response was there. The FDA has given approval on oral miltefosine, that is Profunda. This is 550 milligram thrice a day for 1 month. So there are some papers on refractory acanthamoeba. So we tried in topical same preparation as has been used in vivo trial, but all of our 5 cases worsened. The only thing was a monotherapy, so no adjuvant PHMB or chlorhexidine was given. So we do not have any further experience of using this drug as a monotherapy or as an anti-acanthamoeba topically.
Any
Dr.
other
Bhupesh?
novel cysticidal drugs?
And word of caution about oral miltefosine. I think there are from India only, there are many papers which shows that in leishmaniasis when it is used can cause toxic keratitis which can mimic like one of the stromal necrotic like acanthamoeba from
Yes.
the eastern part. I think Sakshi from Madhya Pradesh or somewhere, and also Dr. Asim Sil from West Bengal. They published papers, and even
Yeah.
WHO has given a warning also about
Yeah.
this thing.
So this drug has
Dr.
been
Rakhi Kushumesh has
found.
published.
Yeah. So this drug has been found to cause severe inflammatory reaction in cornea in almost 60 to 70% of cases, which Dr. Elmer too published in his experience of 22 patients of refractory acanthamoeba. And that's why he or the team recommended that use of steroids whenever we are giving miltefosine, and that's why there's not that much famous a drug for use of for refractory acanthamoeba in spite of having FDA approval for this drug.
Also, like Dr. Revati ma'am mentioned about the drug toxicity, it's not limited only to the cornea. Acanthamoeba treatment also causes toxicity on the conjunctiva. Quite often, when you use PHMB for a long time, you can see conjunctival ulceration. And when you see those with a little boggy conjunctiva, you're wondering whether it's drug toxicity or whether it is a scleral involvement. That becomes a little bit of confusion. So, drug toxicity can extend on to the conjunctiva also in these cases.
Especially with 0.08%.
Yes.
I have seen that many times confusing. Is there an underlying scleritis or is it only a conjunctival inflammation?
I think
Yeah, when
one
we talk
point.
about sclerite,
Sorry.
sorry, Dr. Bhupesh, I just wanted a comment from you that many a times we see patients with scleral involvement as it is brought in for the discussion. How would you go about treating those patients, and which are the patients or which are the indications where you would like to add steroids to the anti-acanthamoeba management?
Yes, Dr. Paras. So just a quick comment about the case which last presented. I think Dr. Nikhil also wrote in the chat box that doing penetrating ketoplasty for optical reason in resolved acanthamoeba should be performed usually after 1 year, because recurrences chances are there, and we all have seen the success of these grafts if we are waiting for longer time. So one recommendation is not to be hurry in doing the PK in these cases. Number one. Number two is use of steroids. Yes, there are 3 or 4 indications where you can use steroids safely. One is if you have already treated this infection for more than 3 to 4 weeks and you are seeing some response, particularly if they are not that much deep. Second, if we are seeing that signs of deep vascularization which is increasing. Third is limbitis or scleritis, and fourth is uncontrolled pain. So these are the few indications where you can add topical steroids. And cases where the scleritis are present, they are very difficult to manage. And there are two ways to handle them. First, you decrease the pain and inflammation and anti-acanthamoeba medication. But many cases, when they are referred from outside, they present like a severe guttering around the infiltrate, and that time they are coming with almost thinning of more than 90%. So you need to supplement with TA, but with a close follow-up, sometimes they tend to perforate fast. So we need to be very careful about waiting for so long that they land up into auto evisceration. So there's a two ways of to handle it. If you're having that enough thickness of cornea, you can buy the time by giving anti-acanthamoeba medication along with uh, 2 weeks of waitage and then add steroids if at all limbitis is not there.
Dr. Fogla, my experience with the DALK in acanthamoeba, as in microsporidiosis, the recurrence is more. I have tried a few cases almost, maybe only one case, if I remember, escaped. But otherwise, though we think like, DALK should work, but the recurrence is very common. That is one thing. And another thing about the scleritis, Dr. Dart's group in from Moorfields, they even suggest immunosuppressives, immunomodulators like cyclosporine or other things for this managing this scleritis along with the anti-acanthamoeba medication because it can be a really nasty scleritis, which where immune component may be more than the infective component. I have one patient now on immunosuppression. After almost everything quietened down, the rheumatologist is giving immunosuppressant. Otherwise, we couldn't control her scleritis.
I think timing is critical.
Doctor,
Forming doubt. Continuing the anti-acanthamoeba treatment post-DALK as well. Microsporidiosis, we do not have an effective treatment. So even if you do DALK, chances of recurrence will be there. But I think for acanthamoeba, if you intervene relatively early enough, there are publications that show that you can have good outcome. Somehow, if you wait too long and you develop large opacity, secondary glaucoma is a very difficult condition to manage post because the scarring of the angle takes place. And even if you manage a optical PKP, they don't last very long.
Thank you so much.
so we have experience of doing DALK. I think quite significant number 38 or some we have published in IGO. And Dr. Fogla, being an excellent surgeon of DALK, sometimes there are some certain indications where DALK actually is playing a very big role, and many papers by Donald and Sarnicola group has shown that early DALK can be useful. But with the understanding of these drugs, more than 85% cases respond to medical therapy. If your case is lying in that 15% of category, probably then you can think of doing a surgical intervention early.
Dr. Radhika, your comments, please.
So, yeah, yes and no. I have tried in just about 2 or 3 cases in whom I have got mixed responses. I understand that the infection extends more than the visible limit. So just because you're seeing a clear cornea does not mean it's uninvolved cornea. And acanthamoeba cysts are notorious for staying there for years together and then cropping up later. Unlike microsporidiosis, when it comes back, I feel it's a true recurrence, even if it happens later. So anterior segment ASOCT, sometimes guides me to the decision making. So you cannot determine whether the surrounding or the deeper cornea is clear or not exactly, but you do get some, indication whether this DALC is likely to eradicate or debulk the infection, like Dr. Rajesh just said. Cannot, remove it completely, but how good your debulking will be, the ASOCT is a guide. So I think in the right case, in the right hands, it sometimes works. But a lot of anti-acanthamoeba treatment has to continue later also, and a high index of suspicion for smoldering cysts should be there in the clinical follow-up.
Thank you so much for all the insights. I think in the interest of time, we will move ahead with the next two cases. The first one is by Suyasha Nalvade. She is the cornea fellow at LVPI. Can we have a video, please?
Sometimes the greatest threat to vision is not the injury, but what grows after it. One speck of dust, one instinctive rub, 12 months later, a corneal transplant. This is the story of a pathogen that pretends to be a fungus, but refuses to behave like one. I am Suyasha, first-year cornea fellow, presenting a case of Pythium keratitis. Our patient is a 30-year-old female presenting with redness, pain, diminution of vision in the right eye following dust fall. 7 days ago, like most of us would, she too rubbed her eye vigorously. She was started on topical antifungals for presumed fungal keratitis elsewhere. She now presented with worsening of symptoms. On examination, a central grey-white fluffy infiltrate measuring 6 cross 7 mm, characteristic irregular tentacle-like linear margins, subepithelial dot infiltrate beyond the main infiltrate, peripheral guttering due to collagenolysis, an overlying epithelial defect. AC had a 1 mm of hypopyon. The infiltrate was scraped. KOH and calcofluor white demonstrated broad ribbon-like hyphae with few or no septa, unlike acute angle branching we see in fungi. Grams showed sparsely septate filaments with occasional GNB. Culture grew flat, glabrous submerged colonies, subsequently confirming the diagnosis of Pythium. Zoospore formation is a unique characteristic that we see in oomycetes, confirms the organism's identity by demonstrating its motile spores. A diagnosis of right eye Pythium keratitis was made. Tissue adhesive was applied over thinning by collagenolysis. The patient was started on topical azithromycin, linezolid, cycloplegics, and oral azithromycin and analgesics were started. B scans ruled out endophthalmitis. The infiltrate progressively reduced in size. Peripheral scarring developed. Eventually, the infiltrate was restricted underneath the adhesive. At 4 months, the ulcer healed completely and all antipythium medications were stopped. The next challenge, although infection had resolved, vision had not. The patient was now left with a dense anterior stromal scar directly involving the visual axis. At this stage, two options were discussed, either a keratoplasty or a contact lens trial. Since this was her only seeing eye, contact lenses did not offer her satisfactory vision. Hence, she opted for a keratoplasty. Considering central visual axis involvement, preserved endothelium, a DALC was planned. The patient underwent DALC 7 months after first presentation. Surgical challenge that we experienced was that the big bubble did not cross the scar. Hence, we resorted to manual dissection. Host bed was trephined at 7.75 mm and graft at 8.25 mm. 16 intrapid sutures were taken. At the latest visit, that is 1 month post-DALC, her best corrected vision is now 20/60. The graft is clear, well opposed and all sutures intact. The patient has resumed all her daily activities. Selective suture removal is planned during the subsequent follow-ups. This case highlights several important lessons. Tentacular infiltrates, peripheral guttering, dot-like infiltrates, always suspect Pythium. Correlate with microbiology. Tissue adhesive preserves the globe integrity and helps buy time until the infection resolves. Once infection is eradicated, appropriate visual rehabilitation needs to be offered. In infectious keratitis, saving the eye comes before saving the vision. In this patient, we could achieve both. In cases of Pythium, Pythium wins when we mistake it for fungus, but once we recognize it, even a cornea on the verge of perforation can be transformed into a clear graft and a second chance at sight. Thank you.
Thank you so much, Dr. Suyasha, for sharing your well-managed case. And now we move on to another challenging case, which will be presented by Dr. Shruti Muralidharan, who is a junior consultant at Cornea Services at Shankar Nethralaya, Chennai.
Good evening, everyone. I am Dr. Shruti Muralidharan, Junior Consultant Cornea Services at Shankar Nethralaya, Chennai. And today I'll be presenting a challenging case of pythium keratitis with superadded pseudomembranous conjunctivitis. A brief history about the patient. He was a 28-year-old male who presented to us with acute history of pain, redness, and whitish opacity in the right eye. He was treated elsewhere with empirical antibiotics for about a week before coming to us, but had no significant relief in symptoms. As a routine, we sent corneal scraping for the right eye, the smear and culture of which confirmed the etiology to be pythium. Thereafter, he was accordingly started on targeted therapy with topical linezolid and topical and oral azithromycin. A very important point to mention here is that he was started on oral steroids elsewhere before coming to us, which not only led to worsening of his corneal condition, but also caused steroid-induced hyperglycemia. So he had uncontrolled sugars when he came to us and had to be sent for a physician consult as well. We followed him up closely over the next 2 weeks, and he was noted to have good response to therapy with respect to scarring, in terms of scarring infiltrate and healing epithelial defect, and he was also under the care of physician for blood sugar control. Much to our dismay, at day 14, he presented to us with acutely increasing lid edema, chemosis, and itching. However, he did not complain of any pain or discharge, and slit lamp examination showed that his infiltrate was getting better, so we suspected drug toxicity or allergy. He was managed symptomatically with oral antihistaminics, serratiopeptidase, lubricants, and cold compresses. A couple of days later, he had a marginal improvement in the lid edema and chemosis, however still had a lot of discomfort, but this time pseudomembranes were noticed on examination. The other eye involvement was also noted in terms of a few follicles and SPKs. Then on probing, he revealed history of similar complaints in his wife and son also. We accordingly started him on treatment of pseudomembranous conjunctivitis, and mechanical debridement and membrane removal was done every visit 2 days apart to enhance drug penetration. On close follow-up, good clinical improvement was noted. However, he had massive inflammation in his eye owing to the pseudomembranous conjunctivitis, which warranted use of topical steroids. But in view of active pythium keratitis, we could not start him on the same. He developed a persistent epithelial defect and an inferior area of thinning at the limbus, which was worrisome to us. And to protect these two areas from melt, we went ahead and did a cyanoacrylate glue plus bandage contact lens to protect those areas. Also, topical cyclosporin 0.05% therapy was initiated to take care of the inflammation. So this patient had a dual burden of microbes with combined pythium and adenoviral conjunctivitis, both of which pose their own set of challenges in management. As far as pythium is concerned, it is diagnostically difficult, it is difficult to treat, rapid course of progression, and has a slow response to therapy. As far as pseudomembranous conjunctivitis is concerned, it causes a lot of mechanical irritation and impairs healing, has a high tendency to recur, so requires repeated removal, increases risk of symblepharon and scarring, and of course for both these coexisting cases, there is a need of close monitoring and inflammation control has to be done, at the same time taking care that the infection doesn't worsen. So we managed to do most of these things reasonably well in our patient. Control the conjunctival disease by use of antibiotic, lubricants, and membrane removal, targeted pythium aggressively, focused on reducing inflammation by use of cyclosporin as an alternative for steroids, and closely following up the patient. Surgical intervention is indicated early in cases, especially who are non-responders. Thankfully, our patient responded well to medical management. Thank you for your kind attention, and special acknowledgements to Dr. Radhika Natarajan for her valuable inputs on this case.
Both the
Actually, a
cases were
disclaimer is,
fantastic.
Paras, I should say a disclaimer. It's the other way around. Full marks to Shruti because I was part of the I was partly treating the pythium with her whenever she was asking for opinion, it was her case. But when the patient presented with the conjunctivitis like picture, I repeatedly told her that there has to be drug toxicity. she was the one who unearthed the involvement of the other eye, involvement of the family members, and then went on to describe the pseudomembrane, and then said that, this may not be just drug toxicity, this may be pseudomembranous conjunctivitis. So full marks to Shruti for treating the case appropriately.
It was a double pathology altogether. So a quick question, like what would be the primary drug which you would like to start for these cases?
So I think the combination that Bhupesh has very well described in this paper. So tetracycline means azithromycin and linezolid, and means Zaha, linezolid, and oral medication, if at all we want to give, after checking with the cardiologist.
And would you like to comment about anybody, like, maybe Dr. Revati, like which cases you would suspect possibly you are dealing with pythium keratitis, and you would like to either repeat the scrapings or review your cases?
Yeah, clinically, the guttering is one of the very important clue that it is not simply some other fungal infection or something. And with the keen observation, we can see the tentacle like these things. And whenever what you think as fungal, if it is not responding, then definitely you have to suspect pythium. My most important clinical clue is the gutter as well as the tentacle. Gutter is the most important thing. Invariably, like after some time, you will see that.
Paras, I want to add that it may or may not be, true in all cases, but I feel that whatever looks like a fungus, but the patient is more symptomatic, and whatever looks like a fungus, but the organism grows more quickly, then I tend to suspect pythium, because the symptoms are more than fungus and the growth is faster than a fungus. I don't have a study to prove this, but I've seen this in a lot of pythium cases.
Savitri ma'am, you've worked extensively on unearthing this bug, ma'am. Can you
Actually,
please?
the culture is a very good indicator. When we have sometimes difficulty in the smear, we also say we'll wait for the culture and then confirm. And it grows in 1 day or 2 days. And it doesn't grow like fungus. Fungus rises over the plate. This is, as she showed the picture, it is just flat and very light growth. So in 1 or 2 days, we can be confirmed that it is pythium by the culture.
And ma'am, your comments on the zoospore induction and the potassium iodide stains.
Yeah, we always do that because we want to have a record that we have checked for zoospore. So all our pythium we do the zoospores, but it's not really required in those labs where it is difficult to do such procedures. They can, on the basis of smear and culture, they can always identify. But actually, it is not very difficult. If the microbiologist is keen on doing it, it can be done very quickly. And the IKI stain, I think pathologists would prefer that. It is a bit difficult to do. It requires 65% acid, which can be a corrosive for the microscope as well for our hands and other things. So in Bhubaneswar, LV Prasad Eye Institute, they do it regularly. So there the pathology technician is an expert in that. But we don't really recommend it to be done regularly.
Dr.
I just wanted a quick comment from Dr. Radhika about, do you use, still use, like SN Group has been using cryo application to the recipient rim before applying the, button to
So
the.
yes, Shweta and co had actually done a study which involved a lot of patients. A couple of those were my patients also. So at that time, the demonstration was that if it extends to the limbus, especially since it's notorious for recurrence, pythium is notorious for not getting resolved, and if it leads to a therapeutic PK, recurrence is a big problem. So the edges where you feel are not surgically sterile, the little infection is there. Then swabbing with absolute alcohol and doing cryotherapy has helped. We do it in those cases alone. But then two disclaimers. When I have continued this treatment beyond the paper, of course, I have seen that non-healing epithelial defect because of limbal insufficiency is a problem. It's a smaller problem than the recurrence of the infection. So many a time I combine tassoraphy, temporary tassoraphy along with these procedures, because The TPK with the alcohol and the cryo leaves the surface difficult to heal. A small tasseraphy can help. And also in Pythium, it's true of most infectious keratitis when you do a TPK, Bhupesh may agree with me. Since we are not using steroid in the postoperative period, you can have a picture resembling a graft rejection in the second or the third week. So that should not, especially common in Pythium. So when the third week you get an opalescent graft with an epi defect, then we need to ascertain whether it is just the graft which is failing or whether it is actually a recurrence. Because if you pump with anti-Pythium medication again, the epi defect is going to get worse. So these are the two observations that I have made when I adopt these two, attachment treatments.
Very valid points, Dr. Radhika. And in addition, I just wanted one more comment from either you or Dr. Bhupesh, that the graft size should be quite large as compared to, the other, we do it for fungal keratitis, at least a millimeter or two larger than the clinical involvement of the cornea.
Absolutely.
So,
And in which cases would you, Dr. Bhupesh, in which cases would you sign off and say that now the globe salvage is no longer possible? So does that also happen for Pythium? I mean, that is a very common presentation for us sometimes.
Yeah, so cases where the thinning is quite severe and involvement of limbus is there, and you have deep stromal infiltration along with severe endoexudates. Those are the very difficult cases to manage. And cases which are so important thing is the size doesn't matter if this is anterior to mid stromal as opposed to fungus, because if you see more than 6 millimeter fungus or 8 millimeter fungus, the response is not great. Versus Pythium, the response is, even if it is a limbus to limbus, but if it is not gone deeper or not caused the anterior exudates, then the response is quite good. You need to give therapy, and even if it is involving the limbus, we always recommend to treat this infection with antipythium therapy for at least 10 days, so that the recurrence chances are very, very less.
Purvasha, may I add a quick point here? So there is one anecdotal case report, but it is worth quoting over here by the AIMS group. First author, I think, was Dr. Namrata Sharma. We must remember that Pythium was originally, diagnosed because of his cutaneous and vascular involvement. And later we realized that, it was actually a root rot organism causing agricultural damage, then skin and blood vessels, and then we probably lately realized that it affects the eye also. The point that I'm trying to make is, in their case, I don't remember the patient, it was unsalvageable and they did an evisceration, I think, but that was not end of story. Post evisceration, it went on to cause cavernous sinus thrombosis. The patient died. So this is not to scare us with every Pythium treatment, but we must remember that it's a different organism in terms of its roots. Pun not intended, but it comes from an agricultural background, and also, vascular involvement is possible. So if at all it is unsalvageable and we eviscerate, I think still close monitoring is required in these patients. I thought it's worth quoting that immediately flashed in my mind when you asked that question.
So one
more
question
clue.
by Dr. Fogla, that is there any difference in the outcome of recurrences if you do therapeutic PK? So yes, sir, if you see the data from our institute, recurrences is nearly zero if you treat this patient for with anti-pythium medication and then do therapeutic PK, as compared to before 50 to 60%.
Still, with all these things, even in acanthamoeba and all, sometimes it can go out of your hand. And the most important clue is, even after a TPK or even while treating, if the eye suddenly develops hypotony. Secondary glaucoma is sometimes a welcoming sign, but hypotony is a warning sign. Cyclic membrane, the eye is going for ciliary shutdown, and the infection is really it affected. And maybe in that case, few cases we tried with silicone oil injection, vitrectomy, TPK, large TPK. We could salvage the globe, but still gradually later on they go for phthisis.
Purusha, should I do the difficult job now because we've overshooted the time? And I guess we can just wrap up this session. Usually we close it by 1 hour, and it was so interesting to have so many comments and so many learnings from all the experts and the microbiologists around and the presenters that, I mean, we've overshooted the time and it's almost 9. It is beyond kind of 9 o'clock, so 1.5 hours.
These
Yeah.
questions were
So,
bugging everyone, so I think
absolutely. So based on that, like, we look at, probably a second session on the same, topic, maybe a month or 1.5 month later. So with that, I would like to
a
thank
recurrence, ma'am.
the recurrence.
We need a recurrence.
So I would like to thank all the panelists for sparing their time and giving so many, learning points. It was wonderful to have wonderful cases from all the presenters. I would also like to extend my thanks to our backup team, I mean CSI office, Shabina and Vinay, and the CSI executive committee, like we had Dr. Fogla, Dr. Jayesh, we missed him for a while, and many others who could, comment and give their insight. Dr. Nikhil, he was very active on the chat box to share his experiences. So with that, I mean, I just look forward to the next session on the same subject. And good night, everyone. Thank you so much on behalf of me and Dr. Purvasha. Thank you.
Thank you
you,
so
all the
much, Paras and
presenters.
Purvasha. It was wonderful to,
You were very
listen to
nice.
everybody discuss.
Thank you, everyone. Thank you so much.
Thank you. We all
Thank
can,
you.
put on the videos so that Shabina can take one picture at the closing part. Can you put the videos on, everyone?
Dr. Bhupesh was there. Dr. Jovita is here.
Yeah. Everyone.
Yeah,
Whoever
all
is,
presenters. Yes,
all the
everyone.
presenters, the
Please
panelists, everyone.
put on your video.
Quick.
Yash. Yash.
Only these many. I think Shabina, you can click some pictures, and we have had a full house. We enjoyed the session a lot. Great learnings. And goodbye till we bring in the second session.
Thank you so much.
Thank
Good
you so
night.
much. Thank you, Paras ma'am.
Thank you,
Thank
everyone.
you. Thank you all.
Thank you, Savitri ma'am.
Thank you, ma'am, for being there all.
Thank you. Bye-bye. Good night.
Good night.
Good night.